Welcome to Johns Hopkins Medicine online webinar series. Today, leading experts, Dr. Idralis, Dr. Schweitzer, and Dr. Rajagopal from Johns Hopkins Department of Surgery will be exploring medical and surgical treatments for obesity. Before we get started, we'd like to share a few tips to help you get the most out of this experience. The first part of our program will include an informative presentation from our experts, followed by a real-time Q&A session. Given the large number of attendees today, we may not have time to address every question, but we'll certainly do our best to cover as many as possible. If your question isn't answered during the session, we encourage you to email us at hopkinsseminars@jhmi.edu. To submit a question, simply type your question into the Q&A box and click send. Your submissions will be seen by others watching this presentation, so please note, if you do not want your name attached to your question, please check send anonymously. You can also upvote questions you find interesting to help us focus on new topics and minimize repetition. Please keep in mind the Q&A is intended for general information and should not serve as a medical consultation. This program is being recorded, and we would greatly appreciate receiving your feedback by completing our survey. A pop-up window will appear at the end of our program with the survey. And now we would like to begin our presentation.
Hi, everyone. It's a pleasure to be with you all today. And today we're really going to be talking about a disease that has come to be increasingly recognized both among the medical community, globally, among the general population. And it's part of why you're here today is that, we recognize obesity as really a complex condition or a disease. Within the medical world, in 2013, the American Medical Association actually gave it this designation. And we have seen really major strides in the advancement of all aspects of treatment for this condition. So we're going to be talking about some of those today. Next slide. So understanding obesity means understanding how it affects the human body, aside from just what you see on a weight scale. There's many different organ systems in the body that may be affected. And as you can see in this picture here, everything from the brain to our vascular system may be affected at a really micro level, starting with inflammation that just kind of goes awry. And because this is a short talk, I can't go into all of the details of the pathophysiology at the moment, but it's important to understand that, when someone experiences excess weight gain over a period of time, there are these micro changes that happen at a cellular level that affect the structure, the function of organs, and also their ability to, sometimes even lose weight and maintain weight long term. And that's why it's really important to have good evidence-based treatment for it. Next slide, please. So I'm going to just highlight top level points about some of the aspects of medical weight management. So within that, lifestyle changes above, not above, I should say foundationally, before and in just thinking about, obesity as a disease, lifestyle changes are going to be bread and butter, no matter what you do ultimately. So for within lifestyle changes itself, it's important to recognize there's several different layers here. And when I first, meet with patients in our clinical practice, something that I like to talk with them about is that, we have different aspects of lifestyle that we may be working on, maybe not all simultaneously, but we do need to kind of look at each of these in detail at some point. Nutrition being, principally the first one. We know that nutrition changes really are the major driver of weight change. About 80% of weight loss seems to be impacted by nutrition. Physical activity is about 20%. And this is really a supportive tool for continued weight loss and for weight loss maintenance. And then mental health, stress management, and sleep are areas that we just can't ignore. They don't have really a number to them, but without having appropriate management of mental health and managing stress, without having adequate sleep, you see individuals really struggle to be successful with nutrition and physical activity. So they all ideally would work in tandem. Sometimes we need to attack one at a time, or add as a layer when someone gets comfortable. And so even thinking about your own journey, good to kind of think about it this way. Next slide, please. And then, thinking about within nutrition, what should I eat? What's the best diet? This is always a big question. Unfortunately, there isn't one perfect diet, but fortunately, any, variation of a dietary approach might be okay for you. So I think the important thing to understand is that we, in order to see weight loss, we need to achieve some sort of an energy intake or calorie deficit compared to someone's baseline. And so what we know is that various different diets have been studied, everything from ketogenic to low carb to Atkins, many, many different dietary strategies. And any of them can, work at least on a short-term basis, provided that you have enough of an energy deficit. I think the challenge is, well, is this diet actually appropriate for you and your specific health conditions? Is this something that you can sustain long term? These are the bigger and more important questions that we need to be asking. And so figuring out with your healthcare provider, what are your specific health risk factors or conditions that you're trying to manage that may be associated with weight gain, and then figuring out, well, what specific nutrition changes are going to actually help me improve those conditions, and can I do that in a way that I'm actually achieving an overall calorie deficit? That's probably the right approach for you. And then also putting that into your actual lifestyle context. So, that hopefully will be reassuring that there isn't just one magic diet that you need to be perfect at. And nobody has a perfect diet, right? Everyone lives their life. So nutrition is a very, very broad area. It needs to be individualized. Next slide, please. And then physical activity, as I mentioned, is a promoter of weight loss. It's a secondary goal. It's a very important goal. And there's several aims within physical activity. So one, I mentioned, it promotes weight loss. Number two, it prevents weight gain. Even if someone's diet isn't ideal, for example, during the holidays, if they're able to maintain a high level of exercise during that time period, they may be able to at least maintain weight or, minimize the amount of weight gain they're having. And then really, long-term, more importantly, I think, many people can lose some amount of weight, but then it's really difficult for many, many reasons to actually maintain that weight loss. However, if we can improve our, lean muscle mass, if we can stay physically active, we're going to burn more energy and we're going to be able to maintain that weight loss long term. That's super important. Additionally, we want to improve our overall longevity, cardiorespiratory fitness, and this happens with exercise. And then decreasing abdominal fat, which is actually linked with ultimately our cardiometabolic health. That also happens from exercise. And I'm going to go into here in the next slide. You can go to the next slide. What specifically should we be going towards when we're trying to build an exercise plan? So there's been a lot of research looking at how much exercise someone needs to actually improve their health, whether it's, improving markers of insulin resistance, diabetes, cholesterol, et cetera, and also weight loss. And we know that 150 minutes of moderate intensity physical activity or 75 minutes of vigorous intensity activity are both linked with these improvements. And ideally over time, you build from having some aerobic or cardio activity, as I just mentioned, to also having some resistance training, which is really going to be important for maintaining that lean muscle mass as you're losing weight, and then hopefully just building that strength. And that's going to be the key to helping you maintain a good, healthy body composition and keeping that weight off. There are many ways to achieve the physical activity goal. It doesn't all have to be done in one day or 1 week. Really important, again, to ideally seek the support of your healthcare providers to slowly make goals towards this. Next slide, please. Now, jumping into pharmacotherapy. So there are guidelines that have been set forth by major professional societies telling us, how should we really be thinking about utilizing these tools. So the guidelines state that medications should be used as an adjunct. I like to use the word as a facilitator to healthy lifestyle changes. And so it's not one or the other. It's ideally, in some situations, both. And what situations are there? So if someone has been working on weight loss through, for example, some sort of dieting approach or just an exercise program, they're really having difficulty losing weight and maintaining weight. And we think about, how much weight is considered meaningful weight loss. loss, at least 5 to 10% of their weight. If they're not able to achieve that amount of weight loss and keep it off after, 6 months or more, probably they would benefit from some additional support. And this is going back to how we think about obesity as a chronic disease process that really at a cellular level we need to address. And so, having that background history is helpful. And then also meeting the label indications, because different medications have different considerations based on someone's individual medical history. And then assessing the safety and efficacy as you're going through treatment is very important. We don't want to just continue medication, ad libitum without really seeing much benefit. It's good to really make that assessment as you would do with any medication you take with your doctor. And if you are continuing to see weight loss, having some benefit, then go ahead and continue, increase and optimize the dose as appropriate. And then keep in mind that these medications really should be considered a long-term weight management strategy, not something that we are kind of just using short-term and then coming off of. We know from research that weight loss magnitude and success long-term really is determined by all of the tools together, not just one. And so we know that people are going to be more successful long-term if they're able to stay on medication. Next slide, please. And so this very dizzying table here, I apologize, has the currently available FDA-approved medications, which when I say FDA-approved, there are medications that are approved for short-term use, and these medications here I listed as the ones that are approved for long-term, meaning at least 12 months or longer. Starting at the top, just briefly, orlistat is known as a fat inhibitor. It inhibits the amount of fat we can absorb. About 30% of the fat that you eat in your diet gets excreted in your bowel movements. And then phentermine, topiramate, naltrexone, bupropion, I'm going to kind of bunch them together as medications that work in the brain around appetite regulation, and they are both taken orally. They have different dosing ranges here, you can see. And then for liraglutide, semaglutide, and tirzepatide, these are drugs that fall under the same category of medications many people think about as GLP-1 medications, but probably an appropriate name would be incretin, which refers to the type of hormone that they are mimicking in the GI tract. So they are essentially turning on a receptor in the gut that helps to regulate appetite. And you have multiple signals, both to increase fullness in the stomach as well as in the brain, which really help to control appetite portions and et cetera. And these seem to be the mechanisms by which people achieve weight loss. As you can see in this table, going down with each row, you see increasing amounts of weight loss achieved over a 12-month period. And so we have come really great way in terms of the benefit of medications that we're seeing to really reverse chronic health conditions and change people's lives. So these are the medications. I'm going to hand it off to Gina, now that we've kind of touched base a little bit on the medical side of things. I know there's lots of questions about this, so hopefully we'll get to some of them in the Q&A. Thank you.
Thank you so much. Dr. Rajagopal leads our program at Hopkins for the Healthful Eating, Activity, and Weight program. I lead our division at Hopkins in minimally invasive surgery, GI surgery, and I'm a bariatric surgeon. We're also joined by Dr. Michael Schweitzer, who's our director of the bariatric program, who will be joining us as well and chiming in for the Q&A. So I just want to reiterate again something that Sylvie brought up, which is about obesity as a disease. And it really is a chronic disease, and our focus really should be on ongoing care and management. And this can shift over one's lifetime with changes in metabolism and aging, other health issues that can come that, for instance, might change our ability, put some limits on our nutrition or our physical activity. And so on the whole, obesity, with obesity, there's multiple contributing factors to that, some of which starts with our genes, which we can't control, but we can control some other decisions that we make. And effective treatment also is multifocal. So that includes nutrition, as was mentioned, the physical activity, psychology, evaluation, and therapy. And bariatric surgery is part of this whole process for some patients as well. So that's what I'm going to focus on. Next slide, please. So I'll just briefly mention there are some, in terms of procedures that that can be done to help people with obesity. There are some endoscopy options. These were developed as a means to match the success of surgery, but with a less invasive procedure. So the challenges to these, such as a gastric balloon, as well as the endoscopy treatment to sort of shrink down the stomach by putting a series of sutures in, are costs and access. For these, insurance doesn't typically cover. You're often paying out of pocket for them, and there's limited weight loss and greater potential for weight regain. For the balloon in particular, it's associated with a lot of nausea. They're only FDA approved for a certain amount of time, and then when the balloon is removed, there is weight regain. So there are candidates for these procedures, but it may not be the best solution for a number of people. Next slide, please. These are the surgical options that we primarily offer. And these can most often be done instead of a big incision, a small fingertip size incisions. And the one that's really been out for a very long time is gastric bypass. It was decades ago that we realized that gastric bypass can actually be a treatment for diabetes. And so this has been around for many decades and has a proven track record. The sleeve has been around, I'd say, in the early 2000s. And I think I did my first one around 2006. And in this one, we make the stomach smaller, just like in the bypass, we remove a portion of that. I'm going to go into this in more detail. Another procedure is a duodenal switch, and this has evolved over time to involve just one connection or anastomosis. And that is, you might have heard of this being referred to as SADI. Next slide, please. So just comparing the most common procedures that are done in the United States right now and at our program as well are the sleeve, which you can see on the left side, and the bypass on the right. So let's just look at how these might compare in terms of what they do. When we look at the sleeve, what we do is remove the outer part of the stomach. So we remove about 2/3 of the stomach, leaving the stomach as sort of a long, skinnier tube. This is done over a sizer, so we don't make it too big or too narrow. So it restricts the amount physically that you can eat. It also, at a time, it also is a metabolic procedure. So along some of these same pathways that were highlighted with where the medications work to affect our metabolism and our appetite and how full we feel. The surgery works along these pathways as well, not just where the incretins are, but as well as other hormonal pathways. This procedure, the sleeve, doesn't involve surgery on the intestine. We remove the stomach so we can't put it back, so it's not potentially reversible. In contrast, the bypass is a little bit more involved, so the procedure takes a more time in the operating room, but the recovery really is the same. The hospital stay is about the same, usually one night, and is typically very well tolerated. So in this procedure, we make the stomach smaller, and we do so by dividing the stomach into two parts. The part that sees food is a very small egg-shaped pouch, and then we bypass around the larger amount of the stomach and the first part of the intestine and connect the intestine up to that small pouch. So you can see in this picture the path of food in red with the arrows. While the food is passing that first part of the connected intestine and that red portion, it's not getting actually fully absorbed until the bowel's reconnected to itself and that food sees those digestive enzymes to help break it down. For this reason, it also has some component of malabsorption where you're not absorbing all the calories you're taking in, particularly fats, but it also imparts slightly higher risk then that you could be more at risk for vitamin or mineral deficiency. This is, though, potentially reversible. Next slide, please. What does it mean in terms of weight loss? So on the prior slides, looking at the medications, it was the numbers that were presented, we're looking at sort of mean weight loss. So if we look at that total weight loss for the sleeve and the bypass, it hangs around 30 to 33 or 35%. We often in the surgery world look at this as excess weight. People want to know, well, how much weight can I lose? I'm over the ideal body weight. So when you look at excess weight, that equals the current weight you're at over or minus the ideal body weight. So for an example, if someone has a body mass index around 40, that's often around 100 pounds more than ideal body weight. And so with the sleeve, patients typically on average will lose about half of that weight. And with a bypass, we'll lose 60 to 80 pounds, sometimes up to 90% of that weight. But it's rare to reach ideal body weight. That happens in a very small percentage of patients. Next slide, please. How do we compare in terms of outcomes? So when we look at the sleeve, it is a shorter procedure. There is some risk of developing or worsening acid reflux. And so for this reason, for all of our patients, typically at Hopkins, we want our patients to have an upper endoscopy first, just to make sure that everything looks good in the stomach and the intestine, first part of the intestine and the esophagus, so we can make sure that patients are the right candidates for these procedures. There is a greater risk for weight regain after the sleeve. Sometimes this happens by the stomach sort of stretching out. And then the bypass is longer, but the hospital stay, as I mentioned, is about the same, and the recovery is similar. It is an excellent operation for acid reflux compared to the sleeve. It is a better diabetes operation, and there is a lower risk of weight regain, but there is a greater risk of vitamin deficiency. About 20% of patients might develop an ulcer. People more at risk for that are folks who take a lot of ibuprofen or Advil. There can be something called an internal hernia, where because we rearrange where the bowel is located, that in a small percentage of patients, about 20%, that intestine might twist, and those patients might need surgery to correct that. And then some patients might experience something called dumping, which is not a threatening procedure, but people can feel ill if that happens, where they might experience nausea or abdominal pain and cramping, maybe some dizziness. And this is because this can happen when patients might take something like unbalanced carbohydrates or sweets, because the bowel isn't used to seeing food that early in the digestive tract, and often dumping can occur. Usually that's managed, it goes away on its own, can be managed by avoiding those food triggers if patients do experience that. Next slide. So what is the typical recovery after bariatric surgery? Again, nearly all patients, particularly in our program, are eligible for a less invasive surgical approach through small finger-type incisions. We have an enhanced recovery program at Hopkins that we've developed to help manage pain, to improve the pain control while minimizing nausea and other medication side effects. Our patients start liquids the very day of surgery. They're up out of bed. We encourage them to do that and to walk. And the majority of patients are ready to go home the day after surgery. We certainly make sure that they are ready to do so, and the dietitian meets with our patients afterward, the day after surgery, to just reinforce and help them prepare for home. Next slide, please. For bariatric surgery, it is an effective weight loss method, and it helps patients do so while still feeling full as you're eating. So often on a diet, sometimes it's hard to sustain that over time because you're restricting the amount that you eat, but you still are feeling hungry. And so this does help with this by making the stomach smaller, so it's physically smaller, but also it helps suppress appetite, so you don't feel that hunger drive as much. And it improves that hormonal response to help you feel full and helps maintain a good, healthy metabolism. Sometimes with very severe dieting, we can lose weight, but then it's hard to maintain over time because it's hard. You often feel like you have to eat less and less or exercise more and more just to help maintain. So this acts on pathways similar to the medications like semaglutide and other pathways as well. Overall, the bariatric surgery is a safe surgery with a very low complication risk. It's really on par, if you look at overall risk, about the same as getting one's gallbladder out. The risk of death is low. It's 0.1%, so 1 out of 1,000. Weight loss is rapid initially, and then will tend to slow down over time. It tends to plateau around 8 to 12 months after surgery, and this may vary from patient to patient, but that's the average experience. About 75% of patients are able to stop their diabetes and high blood pressure medication. In fact, we watch that very closely. Oftentimes, even the day of surgery, we have to monitor patients who come in on insulin. We have to lessen that dose even the day of surgery before any substantial weight loss. And that's the diabetes treatment effect of these surgeries. We also see an improvement in other obesity-related disease, such as sleep apnea. And over the lifespan, there's been proven studies showing lower heart disease risk, lower risk of certain cancers, and improvement of the lifespan. Next slide, please. The next slide, please. Thank you. So, sorry, can you go back? So we have a comprehensive lifetime surgical nutrition program because we recognize that obesity is a chronic disease. You know, we treat high blood pressure. Some people will be treated with diet and exercise alone. Some people are on one medication. Some people, that medication might work for one person, but not another person. And some people are on 2 or 3 medications. So obesity, in my view, has different aspects to it, and we want to continue to work with patients over time. So we have a follow-up that's pretty regular over the year, but we want to continue to support our patients. We have support groups, our dietitians work with our patients, and we want to keep seeing our patients at least yearly after that first year. We want to ensure that all of our patients are taking the recommended vitamin and mineral supplements, and to do so for life, regardless of their weight loss. And that's easy to do now because there's a complete bariatric vitamin that we typically recommend. We do nutrition labs to check these vitamin mineral levels to ensure that that the health is maintained in these areas. And we're also recommending that our sleeve gastrectomy patients get follow-up with endoscopy because of this risk of acid reflux. Next slide, please. So you'll have the, if you decide for bariatric surgery, you'll have some follow-up visits with us, as well as the nutrition consultation with the dietitian. This happens, if there's a weight regain, this is where we start. And we also give consideration to another psychology evaluation or adding in cognitive behavioral therapy as indicated. For some patients who undergo the sleeve, they might consider change to another procedure. But that again takes a rigorous look at, if this would be the right thing to do, because it's a reoperative procedure, there might be added risk. And we collaborate very closely with Salvi and her colleagues in the medical obesity program. We engage again with nutrition and activity counseling and settings of medical therapy. We can add medical therapy for patients who have had bariatric surgery. That's a possibility. And there are some endoscopic treatments that can be done after bariatric surgery to help enhance fullness, for instance. Next slide, please. So I'll turn this back. We wanted to make sure we have enough time for all of your questions. Thanks again for joining us. I can just run through this. If you have a question, please type it into the Q&A box, as was mentioned. You can just press send. You can also send that anonymously. To request an appointment, you can fill out our survey, and that's available with a QR code as shown on that screen. And at this point, I'll turn over and introduce my colleague, Dr. Michael Schweitzer, who is our director of our bariatric surgery program, and will be addressing some of your questions. Okay, so the first question is eating without focusing on weight. Salvi, what do you think about that?
Okay, hi. So intuitive eating is, I think, a general can certainly help with weight loss. I think doing it just in the absence of focusing on weight loss, you may not be, for example, working on weight loss specifically. If you're just kind of thinking about how do I eat healthier, focusing on my body's signals, I think that's certainly a fine approach. I think thinking about it in the space of, well, am I improving health markers? Do I have obesity? Do I have obesity and is it affecting my health? You might need a little bit more of like a close follow-up to figure out, is your intuitive eating approach working for you? And so I think it's kind of a broad way of thinking about eating, which is probably healthy for people in general, but it kind of needs to be, again, individualized based on what your goal is. So I would say that we do encourage that generally, but it's a little hard to kind of say that that's a blanket approach that's going to work for every single situation.
Thank you, Salvi. I think another question for you.
Yeah.
Are you seeing better results for people on a whole food plant-based diet?
Yeah. So a whole food plant-based diet, the idea behind it is that we are preserving nutrients, from foods as they naturally grow. And also there are inherent properties of foods like fiber, vitamins, minerals, nutrients that are great. And they may have some properties that help us stay full longer and help us with weight loss. I think in an isolated vacuum, that's amazing. However, in the world that we live in, where people have jobs, people have limited budgets, people have all sorts of things, it's not really that easy to actually have your entire diet be whole foods and completely unprocessed and even be plant-based. And I'm saying this as someone who eats a mostly plant-based diet. So I recognize that everyone has a different approach, and that is not the only approach that can lead to success when it comes to overall health or weight. And actually, when you look at, there's really, unfortunately, with nutrition, limited, really well done research, and it's hard to do good nutrition research because of many reasons. That you can't actually account for all these different variables when you're following people's diets. But of the dietary approaches that have been studied, the Mediterranean dietary approach and the DASH diet, these are two dietary approaches that are pretty similar in that they do prioritize less processed foods, but neither of them excludes animal meat. They maybe deprioritize it compared to, for example, a carnivore diet. So again, it doesn't have to be an all or nothing. I think it's more having some amount of moderation with things that are maybe not so good for you specifically. So I hate for it to be kind of a general answer, but really it has to be individualized. So
Thank you. Dr. Schweitzer, can you comment on this about the metabolic benefit of bariatric surgery, and if you see the weight loss more with fat versus muscle, and how that can be addressed?
Yes, clearly the metabolic benefit of fat loss or weight loss from fat is extremely important, especially intra-abdominally. That fat inside that's around your organs is the worst type of fat. It just doesn't sit there. It actually is involved and unfortunately gives us diseases like diabetes or fatty liver. And so it is important that we address that. And surgery does an excellent job, along with the GLP-1s, in losing that fat around the organs, which is much more important. And obviously the idea is to try and not lose muscle. And so we focus, especially our dietitians, on maintaining that muscle, getting in enough protein every day, and we have you track it in the beginning so that you make sure that you're getting that protein.
Thank you. I know that you and I have seen a number of patients who come to us for bariatric surgery who've been on medications before, including phentermine. Selby, can you tell us a little bit more about phentermine? One of the
Sure.
Attendees asked if it's still on the market. Can it be bad for your heart?
Sure. Yeah. So phentermine is the second oldest drug that was FDA approved for weight loss. It's of the two back then, it's the only one that actually is still around today. So it is currently on the market. It has actually kind of two different labels depending on how you're taking it. So phentermine by itself is one among a number of drugs known as sympathomimetic drugs. They work, what we think they work on is the norepinephrine neurotransmitter in the brain, and it seems to help people feel a greater sense of just kind of satiety without the need to have food intake to achieve that. And so, so it has an FDA label for 3 months use. It is also part of a combination drug that's FDA approved for weight loss, which includes phentermine as well as topiramate. So you can take either or both of them, depending on, not both, either or the combination drug, I should say, depending on, again, where you are in your journey with all of this. And the way that I would think about it is, how much weight loss are you looking to achieve for your specific goals? And then, what would make most sense for you. Now, when it comes to the heart issues, so if somebody has a background of a structural heart problem, like valvular heart disease, or a condition where they have some sort of arrhythmia like atrial fibrillation, these would certainly be conditions that would preclude someone from being on a stimulant. So sympathomimetics are stimulants. So by definition, they can increase the heart rate. There's a theoretical risk of increasing blood pressure, but more typically it's heart rate. And so if somebody has a background of significant heart disease, whether that be congestive heart failure, structural valvular disease, arrhythmia, I would definitely not put them on this medication. However, if you have, hypertension on its own, if you have high cholesterol, that in and of itself does not preclude you from being on phentermine. In fact, those conditions often improve because of the weight loss that is achieved with the support of phentermine. So hopefully that helps clarify.
Thank you. Dr. Schweitzer, I mentioned in the presentation about the importance of getting the vitamin and mineral levels checked and taking those supplements. One of the attendees asked about vitamin absorption. Does this increase when the stomach stretches after bariatric surgery, whether that's a sleeve or in a bypass?
Well, not necessarily, but increasing the amount of food you're taking in, depending on the type of food, may increase the amount of vitamin you take in. However, with a gastric bypass, you're still bypassing that first part of the intestine. It's not seeing food, and a good part of the stomach is not seeing food. So we still recommend that you take your vitamins to stay healthy.
Thank you. A lot of medication questions. So the first one is about chitosan. Do you see any benefit of this in terms of a weight loss plan? And then someone asked also, are there any age restrictions or recommendations for older patients, particularly women over 70?
Sure. So I don't even know how to use, you probably know how to say it better than I do. I obviously haven't come across the chitosan or tritosan. I had to look it up really quickly, but it certainly is not something that has been rigorously studied. It's not, FDA regulated or approved. It is a supplement from what I can tell. And while it may have some properties that have been studied in sort of what we would consider preclinical research, to impair or help with fat absorption versus elimination. I'm not sure that in humans we have enough data to actually support its use as a clinically meaningful and safe tool for weight loss. So I can't actually make a recommendation for that. And the other thing to note about all supplements is that, they are not regulated. They're not subject to the same rigorous testing and verification of safety as compared to the FDA approved medications. And so really proceed with caution when you're thinking about taking a supplement. Please communicate with your healthcare provider what you're considering taking. And there have been, many cases where people actually get quite sick from some of these types of supplements that have really grandiose claims around fat burning and weight loss. So just be careful. When it comes to age restrictions, there are actually no age restrictions for medications. Really, the important consideration is what are these potential contraindications, and as you age, people tend to have more health conditions. And so if they have, a number of health conditions such as glaucoma or heart disease, right, these are things that might preclude them from being on certain medications. For incretin medications like the GLP-1s, specifically, neither, heart disease nor glaucoma, as I mentioned, are contraindications. So we have, plenty of patients that are over the age of 70 taking them.
Great, thank you. I would echo that about the chitosan and herbal or other supplements. They are not regulated by the FDA. They can sometimes be contaminated with other substances that you would not want to take. They can interfere with blood clotting as well as bleeding. So you want to make sure you share any supplements that you're taking if you have any procedures or planning any procedures to be done, just to limit your, the risk of that happening with the procedures. Just a word of caution. And the chitosan is developed, as I understand, from like some crustaceans, like crab or shrimp. So it's not for everybody either. If you have a shellfish allergy, of course, you should avoid that. Okay, so some questions in here about surgery, Dr. Schweitzer. Does surgery help with the leptin signaling pathway? And then another question is really about more specifically about candidates for bariatric surgery, if there are stomach issues like watermelon stomach, if people have had kidney stones before, does that affect eligibility, or can it avoid kidney damage in patients with diabetes?
Oh, good question. So leptin is kind of complex in that it helps to signal to the brain that your body has enough energy, it's full. And bariatric surgery can and cannot help it necessarily. It can be a ratio with some of the other hormones in the body that bariatric surgery does help with that signaling. But it is a pretty complex question, and it's not fully understood. And leptin never really turned out to be the magic formula for losing weight. Obviously, the GLPs have so far. The next question was about kidney stones. So gastric bypass can increase your risk of getting kidney stones. So if you're have a problem in the past with kidney stones, you may wind up with a problem in the future with kidney stones. The sleeve gastrectomy patients tend to do better with that if they have a history of kidney stones. However, with both operations, the most important thing is to stay hydrated and to keep yourself hydrated all the time, because that's going to cause you to get more kidney stones, even with the medications too. Staying hydrated is number one.
Yeah. The gastric bypass puts patients more at risk for kidney stones. Again, taking the vitamins and the hydration is important. Sleeve gastrectomy, there can be some risk as well, but it's less than with the bypass. What about patients with, can it help reduce the risk of kidney disease associated with diabetes? And I would say the answer to that is yes, in the way that bariatric surgery is a good treatment for diabetes. Would you agree with that?
Absolutely. It has been shown to improve kidney function also. But it does improve diabetes and improves hypertension too.
Great. There's another question as well about, that an attendee has read that some doctors remove the gallbladder at the time of surgery as a standard or based on risk factors. In my own practice, it's really based on patient's presentation. So there are a lot of patients out there with gallstones. I know early on, like 20 years ago, we used to study patients, or at least, in my training and fellowship, to see if they have gallstones. And if they did, we would consider removal of the gallbladder at the time of a gastric bypass. But nowadays, if someone has symptoms of their gallstones, to begin with, it is reasonable to proceed. Otherwise, I'd say it's not standard at all to remove the gallbladder at the time of surgery. What is your practice?
Yeah, not anymore. In laparoscopic age, we don't remove gallbladders unless they're already diseased, meaning patients are having symptoms from the gallstones or have gallstones. But we do put patients on a medication called ursodiol for 6 months to prevent gallstone formation. And the reason for that is that's the rapid weight loss phase. You lose the most weight in the first 6 months. And when you lose rapid weight, you can form gallstones, whether that's surgery or medication. If you lose rapid weight, that's how you form gallstones.
Thank you. Sylvie, some questions about the GLP-1 agonists, sort of how to improve an effect with it. There's a question about taking Metamucil. Prior to meals, can that act like GLP-1 meds? Are there foods that can help improve or increase the response, like a GLP-1? And then there's also a question here about if someone takes GLP-1 agonists, like semaglutide, but does not have diabetes, how does that affect their risk of developing diabetes down the road or after they stop a medication such as this?
Sure. Yeah, I think we can talk first about what the mechanism of action is, and that might help clarify questions around diabetes risk. And then actually that will probably relate as well to the fiber question. So as I mentioned earlier, incretin medications, which is the broad class of medications, including this one receptor that known as GLP-1. This is a gut hormone that regulates our insulin production around meals. So and actually this hormone receptor is actually in other parts of the body, but for the purposes of this particular talk, we'll leave it at the gut. And so yeah, so what happens when you eat a meal? GLP receptor gets signaled, turned on, and that sends a signal to the pancreas, which is the organ that produces insulin. And so when insulin is made during a meal, it's an appropriate production of insulin. You have a decrease in blood glucose because the glucose that's getting absorbed from food goes into the cells to allow the cells to operate and to give you energy. That's a normal response. That response seems to be dysregulated in people who have type 2 diabetes because even if they have that GLP-1 receptor turned on, it's just not working as well. And so they're not able to actually produce insulin the way that they should around meals, and thus their blood sugar can rise higher. One of the other effects of insulin production during mealtime, which is the main benefit for weight loss, is that insulin actually then acts in the brain to suppress appetite around that mealtime. So people tend to find that they don't feel like finishing the meal. And then a second effect that we see with this particular hormone receptor getting activated is that food stays in the stomach longer between meals. So you eat a meal, you're just full longer. And so you don't actually think about snacking perhaps between meals. And so these effects, what we know about these particular medications is that they are actually working much longer than just during that mealtime. And so the half-life, for example, of the injectable medications that are now most commonly used, semaglutide and tirzepatide, is much longer, and they're once-a-week medications. Even still, it takes a few weeks actually for the medication to fully be out of the system. And so keeping all of that in mind, it's really difficult to mimic that with oral fiber intake alone. However, there is a property in some types of fiber, particularly soluble fiber, which is found in things like beans, lentils, whole grains, etc., whereby there actually is a turning on of that GLP signal naturally in the body. And so, yes, there is some, kind of momentary benefit. And that is why we often say that eating more fiber helps people stay fuller longer. So there is some benefit. I think the magnitude of the benefit is going to be different, and the duration of the benefit is going to be different. So hopefully that answers both of those questions. I think with the diabetes piece, again, because we're controlling blood sugar with these medications, they're very, very good at really preventing diabetes and at controlling diabetes if you have it, so that you're not going to get diabetes.
Great. I'll just ask a question as well about the incretins and when do you stop them? We know that when you stop them, there's a weight regain. And then how do you wean off the medication? And if any patients are considering surgery, whether that's bariatric surgery or some other procedure, it's recommended to hold them prior to a general anesthetic because it does slow down the emptying the stomach and can put patients at risk for aspirating, getting fluid down their lungs. So I'll have both of you comment on that about stopping medications.
So I mean, the anesthesiologists have put out some guidance on how we should be stopping medications before having anesthesia or having a surgery. I think for many reasons, having a surgery that's actually more, technically invasive, in which you're actually involving the stomach itself, but even procedures where you're not having an open, an operation and actual change to the stomach anatomy, just having anesthesia itself, the body tends to kind of shut down some of the processes when you're asleep. And so if you already have delayed gastric emptying through taking the medication, that's going to be exaggerated. And so if you have food in the stomach, there's going to be that risk that Dr. Adrales just mentioned. So the recommendation is typically a week before anesthesia that you would stop the medication. Now, I think always discussing and confirming your specific plan with your team would be important, rather than just kind of assuming that, because there might be some other factors as well. But the current recommendation is 1 week before that you stop it, and then the time to resume the medication would really depend on, the recovery from the procedure and what procedure you had and all that sort of stuff. And then I think the first question you asked was about, how long or when to stop the medication, and about, right, correct? Is that? So,
yeah, like if someone's ready to stop the medication, when do they stop? When do you make that determination with a patient? And do they have to wean it off?
Yeah. So there really isn't, first of all, much literature that can kind of support sort of a safe weaning approach for medications in general. And I think this goes back to that very first slide that we talked about, where we said, obesity is really now recognized that, as a pathophysiologic condition for many people. Some people, don't have, metabolic complications or major, organ damage or major complications, as a result of weight gain. And so, they may feel healthier, which is good. And it means they have time. But at the end of the day, with prolonged weight gain, we know that at a cellular level, there is dysregulation happening, both from controlling inflammation in the body, but also around appetite signaling. And this has to do with this enlargement of the fat cells as we're accumulating fat. And so this is a problem that is very difficult to control with simply the willpower, that people sometimes think about when they're thinking about weight loss. And this is why interventions like medications and bariatric procedures have such a critical role. So when we're thinking about actually managing this condition, we should think about it as a long-term management approach rather than, a simple turning off of the light and turning off of the light. And so I guess the best analogy I can think about is, somebody who is, for example, taking medication for hypertension. Their blood pressure becomes better controlled taking the medication. We don't just take the blood pressure medication off because then their blood pressure is going to get high again. Similarly, if somebody's taking a medication that's really helping to reset that appetite signaling that's gone awry, you take that support tool off, they're going to have a return of that appetite signaling that was abnormal to begin with. And so I think you have to think very carefully about, okay, this medication is a supportive tool. It's something that I really need to be on long-term so that I don't have to take 10 other medications to manage all the complications of weight gain. That's the view that I have for the vast majority of people. There may be select people where there's a short-term period of their life that they've experienced some excess weight gain, and it's something that is reversible. And maybe, we use medication as a kind of kickstart. And for those patients, we can think about weaning, but that's really a select kind of percent of the population of people that I'm seeing in my clinic. And again, we don't have a clear protocol that would tell you, yep, this is the time to kind of stop and start or start. So yeah.
And we know that from bariatric surgery, because if you take the band out, the lap band out, 90% of patients gain all their weight back or more. And so it's a lifetime disease. That's why the balloon is really a useless tool. Yeah. For the vast majority.
There are so many great questions. We're going to try to get through as many as we can in the 5 or so minutes that we have remaining. There's a question here about liquid diets before and after surgery, and I'll just answer that quickly. We do in our program put our patients on a 2-week diet. It's not just a liquid diet though. It's some protein shake replacements, but also reasonable food, recommended food that is lean. It is a very strict diet, low calorie, low carbohydrates, low fat, but it's really designed not so much for weight loss as to prepare the liver, because when there's extra weight added on, some of that's housed in the largest organ in our abdomen, which is the liver, and it lays over the stomach. And to keep patients safe, in order for us to have the room to do the surgery itself, that's why we ask all of our patients to do that diet. It's very, very important to help reduce any risk of any liver issues and to give us the ability to see and do the work. But there's a question here about weight loss medications and bariatric surgery. Are they ever indicated simultaneously? I know we have a number of patients who have been on the medications, but are seeking bariatric surgery. So there's a question about that, which I'll ask for both of you. And then also the follow-up to that is, do those medications provide additional weight loss on top of what you might expect for bariatric surgery if someone is on both of them when they come in?
Mike, do you want to go first when you think about referring someone for medical?
Right.
Yeah.
So I think we do work together on higher BMI patients would be probably one area where both together are important, meaning the medication first and getting the patient a little more healthier. Usually the heart is strained, and then doing the surgery in combo is probably safer. Unfortunately, the insurance companies don't always let us do it that way, even though it is a safer way to do it. So yes, and also I think some patients need both, and they may need medication for life too. And again, that's kind of at the patient level, and I can't say that everyone needs that, but some patients do.
Yeah, and I will just piggyback on that because I have seen a few of the patients from Dr. Adrales and Dr. Schweitzer who they've had this procedure done, perhaps a sleeve, and maybe, you know, they just needed a little bit of extra support. And once they had that extra support, it's like we put the key in to unlock. They're just golden. And those patients, the ones who have had surgery and then started medication, are some of my most successful patients because it's just like everything kind of is cooperating for them. And they're really, it's amazing actually. So I think, yes, they can lose more than 30% of their body weight. They can lose much more than that, if that's really indicated, but they can. And it's a beautiful strategy for some patients that really struggle with severe obesity.
At what time frame after someone's had bariatric surgery would you feel safe about saying, okay, we should add on a medication? Is it after the 12-month time frame? Is it earlier than that when the weight really is starting to plateau or appetite is picking up again?
This is a good question, and we're working on answering it. But usually patients are not hungry for the first 6 months at all. They have to remind themselves to eat after bariatric surgery. That's an average. I think following the patient, which we do, and watching their weight loss curve, you will hit plateaus along the way. But if they hit a long plateau and they need extra, then we would consider medication at that time.
Great. We are running out of time, and I just want to add in that I'm sorry we couldn't get to all of the questions, but if you look at the email here on the slide, you can submit a question there, and we'll do our best to answer it for you. Please capture the QR code there and fill out our survey to request an appointment. All right. Any last words from either of you about obesity and the treatments that we can offer? From my point of view, I think it really is there's multiple factors that contribute to obesity, and I think the treatment requires that as well. And so I know at Hopkins, we work very closely together. There's a question there about research. Are we working, to find out more answers, how to best treat this obesity? And there are many physicians and researchers that at Hopkins that are doing that. Selby?
Yeah. Thank you. I mean, thank you all for your time, attention, great questions. Clearly, there's so much interest in understanding this disease better and how we can best tackle it. So, I definitely encourage you to keep asking your healthcare providers, for support if you need it. We're, hopefully we'll offer another sort of resource for you all if you need it in the future. Thanks.
And Mike?
And thank you all for coming tonight, and excellent questions. This is a tough disease. It's a chronic disease, and we look forward to helping you.
Thank you, everybody, for joining.
Bye.
Okay.